The first one, Wilma, when should I call 911 for difficulty breathing?
So the decision to call 911 is always when you feel so short of breath or you can't swallow and you're very, very concerned or you're choking. But it's never too early to call 911. That's the other thing you need to remember, because you can rapidly go downhill. Okay, so if in the morning you're getting up and you cannot swallow breakfast, you might have time to get to the hospital, but by supper time you might need to call 911. So do not hesitate to call 911, I think. So there's no real direct answer. You're feeling you can't swallow and you can't breathe enough to walk to the door, you call 911.
So is there a relationship between myasthenia gravis and lupus? Charlene?
Lupus and myasthenia are both autoimmune disease. And so we find both within individuals who have myasthenia a greater incidence of a variety of autoimmune disease. So be it pernicious anemia, which is a B12 deficiency, vitiligo, a loss of pigment, rheumatoid arthritis, lupus. And the other thing is we often find a increased incidence within the family members of some type of autoimmune disease.
Janice, does CellCept or prednisone lower the effectiveness of birth control?
I don't know of a mechanism for that, or that it exists.
Okay, I think
But someone else
with
may.
CellCept there may be
There may
a
be
lowering.
a lowering.
Prednisone, no.
I did not find that last year when we wrote our myasthenia pregnancy, the most recent one. But
So it's something you need to discuss in detail with your obstetrician, your gynecologist, your practitioner, family practitioner. Let's go.
Chip, she was just suggesting that we at least make the comment about the effect on the fetus of CellCept.
Yeah.
That's a different topic, but CellCept is contraindicated in pregnancy because of its potential teratogenic effect on the fetus, meaning fetal defects, and carry a big stick, right? Speak louder and carry a big stick. So did everyone hear that? So CellCept is contraindicated in pregnancy. And the reason being that it can cause defects in the baby, fetal defects. And so we would typically advise women of childbearing potential, women who plan pregnancy. I mean, first of all, we would encourage planning pregnancy, but any woman who is of childbearing potential, if on CellCept, should be taking birth control. And because of that potential effect on a baby. It's not 100%, but there is a risk for that.
So, and I would also add that the FDA is mandated through their REM program that any woman of childbearing age has to be registered. And there is material that the physician needs to read, material that the patient is given, and then they sign an affidavit essentially stating that they're aware of this material and understand the risk to them should they become pregnant.
We recently received a notification that men who are on CellCept also needed to take precautions not to produce a child at the same time. That was a new thing that just came out recently in Canada. So we've changed our product information sheet for patients that includes men and women.
Another question here is, what research is being done regarding children with MG?
Well, doing research on children of any sort is a challenge because of ethical considerations regarding the ability of children to voluntarily agree to be a part of research. However, the other end of that is that we are mandated to study new drugs in children. So it's really a double bind, and we're sort of caught. So I think suffice it to say that the first step is to show that the treatment is safe in adults, if that's the issue, and then to see if there's a way in which the treatment can be extended to children. I don't know of any absolutely great way to do research of new therapies in children. Chip, maybe you have ideas about that.
Well, it's exceptionally difficult. There's no question. I know we're in the process of developing a pediatric trial with eculizumab that will start probably 2017, 2018. And it's mandated by the FDA and the EMA that this be done, more by the EMA, which is the European equivalent of our FDA. So there's no question that pediatric trials are going to come about with newer therapies once they've been proven efficacious in the adult population. The outcome measures clearly are somewhat difficult because the age groups that the EMA is talking about is 8 years old. And the Japanese regulatory agency was telling us 6. So we've got our hands full, so to speak. It will be a challenge. But these are things that are going to have to be done with any new therapy in any discipline if we're going to get FDA approval for these drugs in pediatric populations. One of the questions, Julia or John, perhaps both, is does MG cause pain and how to best deal with it?
I can start on that one. So in research, MG doesn't cause pain, but we know that with weakness, we often use our muscles in ways that they're not necessarily designed and to compensate so that we can still get those movements done. And also with the weakness and lack of endurance, we often have poor posture. So although it may not be directly related to the MG, because of the weakness and endurance, a lot of people do have pain. So I think that that's something that can often be addressed with your healthcare team, specifically physical and occupational therapists, sometimes chiropractors, but they're kind of hit or miss, in my opinion, to try to address some of those postural and weaknesses and relieve some of your pain. Do you have anything to add?
Not much. No, in and of itself, myasthenia is not going to cause pain per se. But when you hang around all day with your head droopy, or you're on your feet a lot and your hip abductors, those stabilizing muscles, are weak, of course there's the potential for pain. As the muscles that are working are trying to compensate and keep you upright, keep your head up, and keep you from falling. So, in and of itself, no, but indirectly, sure.
That's certainly the way we feel and is taught about myasthenia. However, in surveys that are done of patients with myasthenia, pain is a very frequent complaint. And it's going to be very interesting to see what comes out of the surveys that you folks have just completed. How many of you have indicated that pain is an issue for you?
One of the things that came up in the mature adult group, we're all old.
Speak for yourself.
Feeling old, speak for myself, is when frequently people who are of a certain age and have myasthenia and may have other issues associated with aging. Some of those are naturally going to be aches and pains. And speaking for myself, as my wife reminds me, I'm not 30 years old anymore. So
I would just comment that in the period of early diagnosis of myasthenia, it's not uncommon to markedly diminish one's physical activity. And when there is generalized weakness in particular, then I think that decreases. And then people get very deconditioned with myasthenia, and to then try to move forward with a regular exercise level is problematic for many. And then in the particular circumstance of starting prednisone with weight gain, and that combination of weight gain and deconditioning certainly sets one up to have increased arthritic issues and beyond. So I would raise that as an issue, and also just make the comment to try to keep that in mind and to be as active as possible. I think Charlene would agree with that, that would be an issue to consider.
On that same topic, so I do have MG, and I think part of the reason why I've been pretty successful with it and able to continue with school and work and social relationships is because I've remained active. And that's been a really important way for me to combat the symptoms. So I empower all of you to, wherever you're at in your physiological capacity, go from there and just try to push yourself just a little bit. Even if you're just stretching every day, that's a form of exercise. Even if you're just parking a few spaces farther from the entrance to your work or the place you volunteer, you're getting a few more steps in, and that long-term may benefit you overall. So it's really individualized, but try to push yourself just a little bit to be more active.
Charlene, is there a low dose of magnesium that is safe to take? It helps with my muscle cramps. Or is there a better leg cramp treatment?
That's always a tricky one. So magnesium is one of the medications that we have on the list of medicines to be very careful with. And a number of times from our OBGYN friends, they use high-dose magnesium and in preterm labor, and many of these women get extremely weak. Their reflexes drop. So it is part of magnesium, even independent of myasthenia. And then you put that myasthenia on top of it, the weakness is much greater. It is important to keep the electrolytes at a normal level. So low dosing caution. I think treating yourself with magnesium, you want to be extremely careful, and even looking at antacids and many medications that are over the counter, they have magnesium. So you want to watch them. They aren't necessarily benign. You want to talk to your physicians about them. And
I'm not sure that magnesium works for cramps. So that would probably be the bottom line. The other thing, though, where I still let my patients use magnesium is mixed with calcium because it stops you from being constipated. So if you do CalMag, it's a low dose of magnesium, and it stops the constipation from the calcium.
Another issue with magnesium that we've run into from time to time in the hospital is that if you're admitted to an intensive care unit and your magnesium level isn't at the point that is commonly felt to be normal, the rule is to give magnesium. And we've had a number of myasthenic patients have a exacerbation or even crisis with that magnesium.
Yes.
So you need to, first of all, try to make sure, alert your physicians that is a danger. But it's a challenge to override these intensive care unit rules. I don't know if you've run into that, Charlene.
I have, and I've actually had a number of respiratory crises. You get in just at the point after that's been infused, and I thought we discussed, I'm involved in all the medications, so it's their policy in the ICU. So, we co-manage many patients, so that is a problem. I wanted to take on cramps after that, so
Oh,
magnesium.
I was going to recommend potassium rather than magnesium for cramps. Works pretty well for most people, and it's pretty safe.
But I also low dose.
Well, yeah, moderation and everything.
But a lot of times, I've heard a number of times people get a lot of leg cramps with myasthenia, and sometimes that's the prednisone. Sometimes that's overdoing it. So if you've had a long day, you're walking a lot, you spend a lot of time on your feet without the proper supportive shoes or orthotics, that may increase the cramps that you get. So stretching is very important. And so that's probably where I would start, is the stretching if you're doing things on your own.
But I used to find that my gin and tonic with quinine would take care of my cramps all the time. What about that?
I think, Chip, you'd be better off with a horseshoe magnet and a bar of soap under the mattress.
But the thing is that quinine is potentially dangerous as well, and it should be avoided. But how about the magnesium in multivitamins? We have patients who are shopping trying to find vitamins with no magnesium in it. Is that wasted effort, or should they adhere to that?
I think it's too small a dose to worry about.
Right, yeah.
But how about Maalox? That's magnesium.
Yeah, I would avoid the Maalox.
Yeah, use another antacid rather than Maalox.
But it's okay to take multivitamins that have magnesium in it less than the FDA allowance. We believe that that's safe.
Any impact from topical magnesium?
When do you use topical magnesium?
Well, topical for what was the question. So I spent an hour and a half in an isolation tank. It's one of these complete sensory deprivation chambers where you float in 100-degree water. And it turns out that the buoyancy is created by magnesium salts. And I found out afterwards and wondered, did I get lucky or no impact from topical application?
I think the answer would be don't swallow. Well, one thing I think a statement that can be made about anything that you take is pay attention to any potential adverse effect on your myasthenia. And that's any of these topical medications, herbs, St. John's wort, anything that you take. If you get worse after you take it, common sense says suspect that may be the reason why you got worse, and bring that to the attention of your neurologist.
And that goes with environmental things as well. So for John, in the hot water, that's one of the potential things that may make the myasthenia worse. And a lot of people have asked about nutrition, and I don't think we're where we need to be to really understand myasthenia and nutrition, but many people have a sensitivity to gluten or celiac disease. So pay attention to what you're eating, eliminate one thing at a time if you seem to have problems. So many things can impact your MG.
And keeping a diary of events like that can be very useful in identifying a pattern. So if something's making you worse, start keeping track of all of these things, what you eat, what you drink, environmental things, so that at the end of the day, you and your physician can look at that and try to tease out what might have been responsible for any worsening of your symptoms.
Does thyroid dysfunction, hypo or hyper, play a role in MG?
Thyroid disease is another autoimmune disorder, as Charlene was speaking of, that is not uncommonly present in myasthenia. It can be hyper, hypo, just autoimmune thyroid disease. And in the setting, particularly a flux of the thyroid state, there can be an exacerbation of myasthenia. And that would mean that it could come with hyperthyroidism, hypothyroidism, or as one is being rapidly shifted even from too high, in particular when it's too high, even back to normal. It's the flux seemingly that creates the vulnerability for temporary worsening in myasthenia.
And that's one of we talked about earlier today, some of the mimics for myasthenia gravis. And as a neuromuscular physician, thyroid disorders are one of the things that can affect the muscle, not only the strength, but how it performs. And so, that may be one of the things that we look for. If fatigue increases, thyroid disorders may increase fatigue, they may affect mood. So it really has a role in myasthenia.
It's been my experience that if one is hypothyroid, that one has difficulty trying to get their disease under excellent control. Not so much with hyperthyroidism, but if one is hypothyroid. And the endocrinologists don't like to, they get it close and they say this is okay if your symptoms are fine. And it's been very difficult to convince them that we want this tuned perfectly. So I would keep that in mind. Does restless legs syndrome go hand in hand with MG?
I would say it doesn't go hand in hand, but there's a number of indirect influences. So as Wilma had talked about earlier yesterday, sleep is very important. And so many people who have restless legs may also have a disruption of sleep from something we call periodic leg movements of sleep. And so really understanding sleep is important. The other thing is with restless legs, the question is what is driving that underlying feeling? Sometimes there's the presence of a neuropathy. Sometimes there's a change in the iron metabolism. So there are many things that may influence the MG from that restless legs.
I could touch on sleep hygiene.
Okay.
So sleep is an area that occupational therapists look at, and it's a passion of mine. So some little tidbits. Everybody metabolizes caffeine a little differently, so there's not like a hard and fast rule, but for most, you should try to avoid caffeine after 3 p.m. Although I do suggest exercising, try not to exercise close to your bedtime because that'll wake you up. Your bed should really just be for sleeping and for sexual activity. You shouldn't be watching TV or doing other things in there that are waking you up. You also shouldn't be texting or watching TV close to bed because the blue light that is emitted from those technological devices changes your production of melatonin. So there are a lot of kind of easy changes to your life that can really change your sleep quality and help you get better quality sleep during the night. And for many people with MG, sleep is a very vital factor in managing their symptoms. I'm pro napping, but but napping shouldn't be hours on end. I'm pro 30 to 45 minute naps, not 2-3 hours. You shouldn't be getting a REM cycle in when you're napping, and you shouldn't be napping after 5 p.m. because it's going to interfere with how tired you feel at bedtime. So I'm pro with a caveat.
So how does MG affect intimacy? How can one help a spouse with this? It's not stated whether the spouse has MG or the other way around. John, any thoughts?
I think that the right answer to that is to work with gravity. That if supporting your body weight is difficult, to find alternate positions that make it possible to engage in sex without becoming physically exhausted.
Are there times that you would recommend with the fatigue. No, if you're very tired at night, because I heard, I'm just very tired.
I guess this is something that we're only going to engage in if we have the energy and the inclination. So whatever your inclination is, whatever your availability is in terms of how you feel physically and how you feel emotionally makes all the difference. Whether you're going to snuggle or have sex or win.
And it counts as exercise.
Does that register on your Fitbit?
Yes, there's a question here.
I have a question. We were talking earlier somewhere, CPAP versus BiPAP, back to the sleep. And I have sleep apnea and I wear CPAP. And one of the patients here told me I should really look into a BiPAP with myasthenia. Do your doctors feel that's something I should look into or not worry about it?
That's something, you have a specialist for everything now. So that is something that you probably should talk to with your sleep specialist. So
with myasthenia, you don't say, yes, you should have it.
Right. So I don't know how many of you know what CPAP and BiPAP are? So, yeah, good. So in terms of the non-invasive respiration, continuous positive airway pressure helps keep the airway open. And that's good as you're inspiring. But if you have weakness, the theory is that it's harder to breathe out against it. So the bi-pressure is a lower expiratory pressure, so you don't have to work as hard. There are some people that still need that airway supported by that continuous pressure. So it really is a sleep specialist who understands what your oxygenation is, what's the best for your physiology of the upper airway and for respiration. So it's variable.
Yeah.
Sometimes there's a humidifier on the CPAP machine. So there's a warming and there's also the humidity, because otherwise you wake up with cotton mouth and it's just very dry, and so it makes it more comfortable to have the humidifier. So it's possible you had some of that condensation.
So the condensation could get caught, the tubing is corrugated, right? So the condensation could get caught in those ridges and then run suddenly into the mask.
So a question is the brain fog some of us experience related directly to MG, or is it a side effect of the drugs used to treat the disease? So brain fog. How many have brain fog?
It's easy for all of us to have brain fog, especially when we're fatigued or not feeling well. And I suspect it's not directly related to the MG nor the drugs, but certainly when you're fatigued, you have brain fog.
But there's also a number of other things. And Gene just going through his emotions was just the stages that he went through with his MG was beautiful. There is anxiety. And so when you're busy focusing on so many other things, you can't attend. And so you don't process things well. Depression is one of the pseudo-dementias. So if you're depressed, you really aren't processing things. So this may contribute to some of the fog and the cognitive difficulties. And again, I come back to sleep every time. If you're not getting a good night's sleep, you are not going to be able to process things. And in those deep stages of sleep, that's when we process our memories in the hippocampus. So sleep is so critical, not only for your fatigue, but also for that MG fog.
So the next question relates to immunizations. Can immunizations precipitate myasthenia or trigger a flare, such as tetanus shots?
Yes. Anything that turns up the immune system can worsen myasthenia gravis, and that's precisely what immunizations are designed to do. And there are a number of cases reported of patients whose myasthenia either began or was worsened after an immunization. Now, having said that, I'll now say that immunizations are good for you and are essential in certain circumstances, particularly if you are on an immunosuppressant agent and getting the disease for which the immunization is designed would be worse than the risk of exacerbation with an immunization. Now, there was recently, I don't know, not that recently, about 5 years ago, a study, I think it came from the north somewhere, didn't it? Didn't it come from Canada? That did a study of the effect of immunizations on a large number of patients with myasthenia. And the conclusion was that the risk is much, much, much less than the risk of the disease for which the immunizations are designed. And I think this was flu vaccine, wasn't it? Yeah, it was flu vaccine. So bottom line is, don't miss your necessary immunizations, but make sure that you are attentive to any possible worsening that can occur after it, and get in touch with your myasthenia physician should you have anything that suggests that you're getting worse after an immunization. I don't want to overplay the risk of that. It is really very, very small.
The vaccines that have live virus, I think, should be avoided. I think that's reasonably good advice. And one of the ones that currently comes up frequently is the question of shingles, the shingles vaccine. And certainly if one is immunosuppressed, that is unlikely to be a very good idea. I've just in the last 2 years seen 2 patients with onset within a couple weeks of getting the shingles vaccine. I would be concerned about that. You agree with that?
So this is one of the other things I like to talk about with my patients. So now we said, don't get a shingles vaccine, but because of the immunosuppression and with stress, you're at risk for shingles. So what do you do? And when you get shingles, it's always it's Sunday morning. When urgent care is closed, your physician's office is closed. So we have a conversation about what shingles looks like. And if you get it, this is one that is worthy of going to urgent care and paying for that high copay at the urgent care if your doc isn't open, or going to the emergency room, which is inappropriate for that. But if you don't treat early and aggressively, pain from shingles is debilitating, or it can be. So or dissemination. So it's worthy of treating shingles aggressively.
So from a case study of one, I had shingles last year, and it's just god-awful. Treated relatively quickly with acyclovir, and the rash went away quickly. Unfortunately, the virus was in the nerve roots running from, I guess, L3, L4, and had leg pain for 6 to 8 months afterwards. Briefly touching on influenza vaccination, this is particularly an issue for anybody who works in healthcare, who is also immune suppressed. If you work in a hospital, hospitals are strongly encouraging staff to get the influenza vaccine. It's become a condition of employment. So if you choose to not get the vaccine, in some places you will have to wear a mask from, I guess, October through March. In other places, it's just a simple condition of employment. So it's particularly an issue. So I guess my question for the panel on this topic is there anything that people with myasthenia can do to optimize their status before receiving even an attenuated vaccine?
I don't know that there's anything specific other than to, take good care of yourself. I don't believe that there are any health supplements or additives that improve the immune system.
I'll just say that I actually had shingles a number of years ago, and the infectious disease doctors did not want me around any of my myasthenic patients on immunosuppressants. on immunosuppression. So, because when we have shingles, we actually shed the virus, and so should a spouse or other close contact have shingles, it would be best if you are immunosuppressed, I think, to stay away from them. That was at least the recommendation. Yeah.
Another thing you could do is take a shower when you first get home and change your clothes. Also, if you carry a backpack or a purse or some other thing, don't put it on your bed, because often we put those down in really dirty places. Those are kind of hygiene things that aren't often talked about, but can really limit the exposure to your loved ones.
So that's what Janice was talking. So Barry said his wife was advised by the internist not to get the shingles because of Barry. And so what I recommend in those family members is if the spouse or other family members are going to get it, that they stay with grandchildren or someone else, because you do shed the virus for several days. So it increases your susceptibility. So
to the panel, has anyone ever seen a patient with generalized myasthenia seronegative with a normal EMG?
It really depends on what you mean by a normal EMG. EMG is not like a X-ray where one size fits all. The EMG has to be done in the appropriate fashion and in the appropriate muscles. Having said that, you cannot have myasthenia involving a muscle in which the EMG, at least the single fiber EMG, is normal.
So the next question is, what's the status of the eculizumab trial? So I'll take that one on. The eculizumab trial with Soliris was a phase 3 international multi-center trial, about 125 centers, about 126 patients. Enrollment closed. The last patient is through the blinded phase of the study as of about 6 weeks ago. The data is now being crunched by the statisticians, and the data will be presented in Toronto on July 7th at the International Neuromuscular Congress. So hopefully we'll have answers by then. Neurologists are often given a number of years after thymectomy that the patient will be better. Is there any evidence on specifically how long after thymectomy that people get better or go into remission?
Well, before the thymectomy trial, we said it could occur anytime up to 20 years. But the real problem is, do you know that if a patient gets better after thymectomy, do you know that it was the thymectomy that made them better, or was it something else, or just the natural course of their particular disease? The thymectomy trial results will tell us when the patients who got it better within the 3-year observation period, when they got better. But it'll take long-term follow-up to know what the results down the road will be, whether the patients who had a thymectomy will continue to show an increasing rate of improvement over the years compared with the other patients. Now, does anyone who was involved in the thymectomy trial know what, if anything, will be done about subsequent thymectomies in the control patients? Was that addressed in the study?
That was just the option. The patient could leave the study at any time if they chose to have a thymectomy.
But I mean now that the study is over.
Will they have or have the option to have?
Well, they obviously will have the option, but is there going to be some sort of follow-up to determine whether the ones who have no thymectomy have a different rate of improvement? I would hope so.
There's currently no super long-term follow-up.
Yeah, that would. I think that's unfortunate. I would hope that there would be long-term follow-up of these patients, either ad hoc by the participants or formally by the organizers of the study.
But a lot of people have, like if they have knee surgery or they have any surgery, a lot of times there's pain along the scar line, like a centimeter or a half an inch on both sides. So that isn't uncommon. And, from unusing it, I've had a lot of patients who've had thymectomy who are afraid to move after the thymectomy because they give limitations on 5-10 pound lifting. So they come back 2 weeks later and they haven't moved their arms at all. And so they get frozen shoulders. So from not using the muscles, so it's possible you see your neurologist, maybe see a therapist to see.
In most cases, these things do get better with time, though, as you say, it may take more time than what's already passed. You mean, does removing the thymus impair the potential for an immunotherapy for cancer? Well, think that you don't normally have a thymus at our age, and taking yours out shouldn't have changed your responsiveness to potential immunotherapy down the road. You've got a normal immune system even without a thymus.
So what Dr. Sanders is saying, that as we age, our thymus gland shrivels and disappears, and it will not have an effect.